Good afternoon. Our next presentation is a panel discussion. Our panelists are Cody Wise, who is a PharmD, Jeffrey Tianson, who is a medical doctor, Reed Groth, paramedic, and they're all from Sanford Medical Center in Fargo. They will be covering and discussing some cases from multiple perspectives. Please welcome Dr. Wise, Dr. Tianson, and Reed Groth.
Everybody hear me okay? All right. My name is Reed Groth. I'm a flight medic here in town. This is my panel of experts, so it's not me giving you education. It's these guys over here. Want to thank Mr. Metzger over here for giving us the opportunity to do this. We're kind of going to do something a little different in presenting. This is the first time we've done it, so you guys are kind of our guinea pigs in this situation. And Jay, thanks for giving us the 1 o'clock slot when everybody's like bogged down after dinner and they're not listening to anything we're saying. So that's really, really great. So let's see if I can get this to work right. What do I got to point at? Okay, give her another shot. This maybe. Oops. There we go. So how I came up with this is Dr. Gary Klein. He's written quite a few books about different subjects as far as why people make decisions and what they do. And what caught my eye for him is he studies aviation accidents for the most part. And he studies fire departments and he studies medicine on why people make mistakes and why people make good decisions. It's both ways. So these are kind of a couple of books that I've read on him and on his part. If you are interested in reading any of these, Source of Power, I would probably say is your last book you should read. It is probably the toughest. My 4th grade reading level, I had to read it multiple times to understand actually what he was saying and pulled a lot out of it every time he talked about or every time I went through it. So this is kind of where I got this idea from. And then Dr. Scott Weingard owns a business called MCRIT. And when I was searching Gary Klein stuff, this podcast came up with Scott and Gary on it. And he talked about this shadowboxing. And then after that, Dr. Weingard did a shadowboxing case. So I'm stealing his case and presenting it to you. So this case that we're going to go over right today, it had nothing to do with our area. This actually happened out in California somewhere, but I think the pitfalls that we hit on here are applicable to anything and anywhere we do medicine. So today, how we're going to do this is I'm going to kind of just facilitate stuff and going to direct answers from Jeff and Cody here. I know what they did. They don't really know what they did, so if they do something different, that's what we're going to hit on. We're going to talk about what's the differences of what you would do and what they would do, and not really which one's better, but which one's going to work the most and why they wouldn't go the route they did. So you have a 71-year-old male that presented to the emergency department with a chief complaint of dyspnea. He's maintaining appropriately. He states that he's felt progressively short of breath for about a week. The team finds him to be hypoxic. His initial vitals are SpO2 of 80%, not good, and has tachypnea and is immediately given supplemental oxygen via non-rebreather. So our decision point number 1, we're at a freestanding ER. So we're going to have to transport this guy out. They transport him out. So decision point number 1 to Jeff. What do you want to hear from me when I walk through the door? What's the main objective when I'm talking to you? Obviously, this patient's sick. What do you want to hear?
You're talking about pre-hospital, you're arriving, presenting to the local ER.
Yeah, yep.
So for me, This, I think, is a little bit tricky. Generally, you want the short and sweet version of what's happening. You know, pretty much with everything that's on that first page. You know, I have a 71-year-old male, shortness of breath, gradual onset. Here are the sort of pertinent vitals. Certainly, the things that are abnormal, pulse ox, if there's hypoxemia and stuff like that, are things that I kind of want to hear first. And then also, if you've noticed any changes, if there was any interventions you did in, if you gave oxygen, if you gave nitro, whatever it is, if there's been a change in status or trend on the way, those are sort of the first things I want.
Awesome, thanks. So one of the reasons I'm saying this to you guys here is like, you know, you guys are the providers. You guys are the ones that are going to be taking information. If you do work at a freestanding facility, if you're not happy with the way EMS is giving you a report, get with your EMS crews and make sure that everyone's on the same page. One of the neat things about COVID, which I don't know, has anyone put that in the same sentence? First time? My job, it's taken me all over. Like, we always have our normal places. You know, we go to cities a lot. You know, we go from one side of North Dakota to the other, all over Minnesota. But I was down in Iowa dropping off a patient about 7-8 months ago. And they had this on their wall. It didn't look like this, but they had the demixed. So I Googled it when I got home. And it's kind of a nice flow sheet for EMS if they get stumped coming into a facility and you have all these people around, they get nervous and they don't know what they're doing, to kind of just, you know, you could point at and be like, here, you know, follow this down. And basically just breaks down, this is how you should give a report. Anything to add on that, guys?
No, I think that's good. And yeah, and a big thing, I like how it was kind of presented in the initial thing, how they kind of gave a brief history on the presentation of symptoms, how it was like a progressive onset, gradual, as Jeff had said, and that kind of can clue you into a lot, because I'm thinking more so like pneumonia, I'm thinking more so pneumonia, congestive heart failure, COPD exacerbation, and I'm less so thinking like a PE or flash pulmonary edema, since that would be a more sudden onset type of thing. So a nice brief history on how the presentation came to be.
And then I would just add a little bit too, from an ER perspective, we don't want to hear their entire past medical history. You'll sometimes get that if you have an internal medicine resident or something where we get 71-year-old.
He broke his leg in 93.
Yeah. Past history, diabetes, cataract surgery last week, whatever the case is. You can skip all.
Yeah. All right, here is what we got. Jeff, you first. What is your biggest concern on this page right now? What jumps out at you the most?
So good question. There's a lot of things here. Obviously, when you're looking at vital signs, really what this boils down to is pattern recognition. You're looking for abnormals. You're looking for things that stand out from what you would normally expect in normal physiology. So the first thing, you go ABC. So there's a lot of things that are concerning here. The O2 sat would probably be my initial concern at 80%. You're going to probably address that immediately if they haven't already put some oxygen on there. The combination of sort of these three major sort of abnormals, the O2 sat's low at 80%. We have an oxygenation problem. The respiratory rate's 50. This patient is trying very hard to make up for that deficit, expending a lot of energy. So those two things together already tell you there's a little bit of a feedback loop going here where this patient's going to get worse, most likely. They probably can't breathe any faster than 50 breaths a minute. They're going to tire out. They're going to generate lactic acidosis and just really putting a lot of strain on their system. In addition to that, the pulse is really revved up, 145, same thing, hyperadrenergic state. This patient's trying to make up cardiac output, the lack of oxygen in the bloodstream. The only thing you can do is try to get more blood flowing, just move it faster, cycle it quicker through the lungs, and the pressure's soft. So all of those things together, tells this patient's pretty sick, probably not going to be able to hold on with these type of vitals to maintain these compensation mechanisms for much longer. So O2 sat number one, but then you add those other things on, it gets even worse after that.
Anything to add, Cody?
I agree.
Concur. All right, so shock index. I talked to Jeff briefly before this, what do you know about shock index? He's heard of it, but hasn't really used it for the most part. I'm on the same boat. We don't teach it very much. My guys and girls don't use it the most part, but nationally going to a lot of conferences and doing a lot of septic and cardiac talks, and trauma, it seems like they're moving towards this as a shock indicator, and it's basically just your heart rate divided by your systolic blood pressure. So this guy's got a shock index of 1.3. Normal is going to be less than 0.7, and greater than 1, you're going to have a higher predicator of hyperlactemia and a 28-day mortality. When you compare this to like a SIRS scale, and they did a big study on it, and I have in the show notes, I have where it is, but they compare it to this scale, and it's about 95% accurate when you compare it to the two of them. So without even drawing blood and just looking at this guy, knowing that there's some sort of problem, you can just take the heart rate divided by the systolic blood pressure. So decision point number 2. Are we going to intubate this guy? We're going to put him on non-invasive. What do you think? What's our best strategy for that?
That's our pharmacist isn't going to make that. I would for sure get ready to intubate this patient. I think it would be very reasonable to try BiPAP if there's a component of CHF or even some COPD, and you can get some air moving that high PCO2, if I remember correctly, that you might be able to help by improving ventilation a little bit. So I think this is someone, maybe trial with BiPAP, give them a little bit of time, and if they're freaking out, not getting better, or very anxious, then proceed to intubation. But if it seems like they're helping, they're starting to relax a little bit, their ventilation's improving, they're starting to see a little trend, maybe the respiratory rate's coming down, heart rate's coming down a little bit, and they're looking better, not looking worse at the same time, then maybe continue BiPAP. But I think this is someone either way is going to end up being intubated.
Yeah, and once we decide to finally intubate, and we're kind of thinking about medications, since we're kind of headed in the wrong direction, since he's kind of getting hypotensive and showing signs of like circulatory and respiratory failure, kind of want to pick an induction agent or sedative that's more cardiovascular neutral, such as like etomidate or ketamine. Probably avoid benzodiazepines, barbiturates, or propofol, as those will really kind of drop the blood pressure. Ketamine would be really nice actually, because it provides some bronchodilation, which will help with oxygenation, and then it can also increase cardiac output because it has a little stimulatory nature with some of the catecholamines and such. So etomidate or ketamine would be great options. And then paralytics is kind of the same decision tree, like are they okay to have succinylcholine? Do they have like a crush injury, burn injury, those type of things? Or can they get rock or VEC, which are going to have a much longer duration? So if they're going to be hard intubation, probably avoid those. But,
All right, so they put him on non-invasive, which I want to just talk about briefly about non-invasive. I know, where we work, obviously we call RT, they're there in the matter of minutes, and they are able to put them on CPAP or BiPAP in the matter of minutes, which I think this guy probably needed an intervention in the matter of minutes. If we're trying to do something around the 11, 12-minute marker of the patient being there, I think we're behind the 8 ball already. Like, this guy needs an intervention and needs it fast. So if you're at a facility that doesn't have RT available and you don't have CPAP, I call this ditch medicine a little bit. And it basically, you create your own CPAP machine by putting a nasal cannula on them at 15 liters, putting a bag valve mask with a PEEP valve on, and whatever you set that PEEP to, that's going to be your CPAP. So if you put it at 10, and you don't even have to bag with it, all you have to do is put it on his face, and that PEEP valve is going to do the work for you. But the important thing is you have to have that nasal cannula on to create that PEEP in his lungs. Is everybody tracking? That makes sense to everybody? I call it ditch medicine. It's probably, you'll probably not see it written anywhere in any books, but it works, and it works. It's a good bridge until you get RT coming in from home, or RT anywhere, or a nurse that can get a BiPAP or a CPAP machine down to you. So that's my ditch medicine for the day. So how are you going to utilize your team? I kind of talked about it a little bit there, but you know, like I was telling Jeff and Cody, like we have all the resources we need. Essentia is the same way. They have all the resources they need in that ER. But if you are at a standalone and it's you and 2 other people, like where do you direct traffic? Like you're it, so you're going to direct traffic. You want to comment on that at all? Or? I know it's not your wheelhouse, but
Yeah. So before I moved back to North Dakota, I worked in Maryland in a smaller sort of community ED, and it was somewhat similar in that it was just you. If you didn't get the airway, nobody was getting the airway. That was it. So I think the lesson there is to recognize, this is a rare event. So these are the things that are trouble. These low frequency, high risk events are things that you just don't do a lot, so you're not comfortable. I usually use the term your brain is on fire when these are happening. So things are going a mile a minute. You've got to slow yourself down a little bit, go through the process, make sure you have all your stuff ready. Where's my card? What blade am I going to use? Get the ET tube out, get the stylet set. Make sure you have your suction on. Don't skip any steps. Pre-oxygenate. Talk to pharmacy. Double verify the meds that you're giving. Take your time. You've got to, even though it's a crazy situation, very important in these low frequency events. You got to slow down, just make sure you're not missing steps. And if it's just you and a couple people, there's not a lot to coordinate. You just got to talk to each other. In a bigger hospital, the main difference is everyone knows their role already. So in some ways, there's always still conversation, but it's pretty brief about confirming the meds. You always confirm by repetition the meds that we're using, and are we ready to push these meds? Is everybody on the same page at that start? So that's probably the big thing. Is just try to take a second, get yourself to try to slow your brain down a little bit.
no one ever gets smarter in the middle of a code, right?
Right. Yeah. During a code's not a good learning. Stuff done. And then on the flip side, this is true for a problem as well. I've been in several scenarios where there's too many people. There's like too many duplicate roles, and there's just then the right hand starts doing something the left hand isn't aware of, so we get duplicate work or we get missed work. So don't be afraid to, or the room just gets too loud sometimes even. Don't be afraid to say one of each role in the room, the rest outside the room, or can take off. And just kind of try to delegate, like, okay, we don't need 3 RTs in here, maybe 1 or 2, the other one can step out. Just try to do crowd control a little bit.
I'm a bit of a bull, so I push my way into a lot of stuff, and I've been asked to leave rooms many times. So I'm working on it.
You need to work, right?
With yes. I'm working on it with HR. They're helping me. Push dose presser. What do you think, Cody? What direction are you going to go on this?
So luckily, I have had very little experience using push dose pressers, just because we have so many premix. Like I can have a premix norepi or epinephrine before the patient's even transferred to our own bed, so I can have that primed and hanging. But in times of a pinch, like it needs to be compounded in the pharmacy, which could take like 15 to 20 minutes or so. These are a great quick option. They're cheap. The ones with the most history will be the phenylephrine and epinephrine. Norepinephrine is kind of emerging in like anesthesia literature and such, but everyone's way more familiar with epinephrine and phenylephrine. They both are diluted down to a certain concentration and then are given as push doses just to kind of keep the blood pressure up and to bridge us to getting the actual drip started. And so phenylephrine, I would prefer a little bit over epinephrine because it has a longer duration, about 10-20 minutes compared to epinephrine, which will be about 5 to 10 minutes. And phenylephrine is a little bit cheaper. It's probably like less than $5 per vial versus epinephrine, which is about less than $10 per vial. So both still very cheap.
Yeah, I've used phenylephrine a couple of times, and I've had pretty good success with it. One of the big pearls on this is, like he said, none of these is going to break your bank. So if you get the call, you get this radio report of this coming in, getting your norepi mixed up and ready to hang, and then you don't use it, throw it away, that's not going to close the doors of your hospital. They're very cheap. They're very easy to just toss something like this in the garbage if you don't use it. Decision point number 2. We don't do it much here. It seems like we did it downtown a lot before we moved to the big hospital, but looking at end title and looking at this gentleman's end tidal. He's talking to us. He's hypotensive. We have a non-rebreather on going at 15 liters. What is that end tidal of 11 telling you? I mean, should we be concerned about that?
Yeah, I think, it's abnormal. There's a couple things. It initially strikes me that it's too low. Are we getting a good waveform would probably be the first thing I look at. Assuming it is a good waveform, the end tidal is a combination of two things. So, air going down in the lungs and then blood being presented to the air that you're breathing in. So there's a transfer of CO2 at that point. So those two things both have to be happening for CO2 to be sort of removed from the body as you're ventilating. So it's got to be a problem with either one or both of those would be my assumption.
So probably not a respiratory issue in the stance of a traditional respiratory issue. This is more of like a shunt physiology being sepsis or cardiac. So we probably need to get him perfused and get his hypertension or correct his hypotension before this comes up. Right? Did I say that right?
Yep.
Okay. I try to make myself look smart by hanging out with these guys. Sometimes it doesn't work. So, all right, what do you think of this, Jeff?
So that is, tacky, irregular. To me, it looks like AFib, although I don't see, fibrillatory waves. There's definitely some artifact, as you get towards the end, to the right side of the 6-second EKG here, but I don't see major ischemia. I think the first thing you think of, you'd be looking for a major cardiac event, you'd be looking for a STEMI, you might be looking for an inferior wall MI, anything, major, an LAD lesion, something that would potentially cause CHF, could be going on here too. But no, I don't see escalation or anything that looks like a big stent.
So, a rate of 120 obviously is too fast for me, but if I saw this in the field, it would maybe be an afterthought. I want to correct the hypotension first. I want to get the respiratory under control before I do anything about this rate.
Yeah. And I wouldn't treat this rate at all, personally. I think this is a normal, granted it's AFib, but it's still pretty regular. The tachycardia is appropriate. If you were thinking about why is the heart rate going up, we're trying to move more blood, we're trying to move more oxygen. This is not an abnormal vital that needs to be corrected because it's abnormal. Think about why this is going on. This wouldn't be, a high priority.
Okay. So the sending ED throws you out these labs. So lactate jumps out at me a little bit, and then a base deficit of 8, which I guess we call that the poor man's lactate, right? Trope looks good. What else jumps out at you?
Yeah, I heard some people out there. Obviously, the white count's a problem. The temperature, I was looking back, was actually on the low side. It was a temporal, measurement. So I'm not sure how accurate that is, but we're pretty close. If you have tachycardia, if you go back to the SIRS thing, or if you just think back on that, you have tachycardia and white count, and the suspected source of infection. This is sepsis, potentially. All you got to do is add that. I think there's an infection here. Now we're talking about SIRS criteria and sepsis. The lactic's high, all of those things just contribute to the fact that this person's not doing well. The higher the lactic, the higher the mortality rate is. So you really want to see that corrected. Kind of a tough situation whether you would, you're going to want to give some fluids here, but don't really know yet if we're in an overload situation or whether there's some other problem going on. So, but definitely the white count stands out. Bicarb's low, the gap's a little bit high. I don't really see anything else. Creatinine kidney function's not too bad. There's really nothing on the legs that really jumps out other than the lactic.
So in my opinion, he's hypotensive. The reason why he's hypotensive until proven otherwise is it's septic shock. That's what I'm leading with. I mean, obviously, if he has a knife sticking out of him and he's bleeding out, that's the source. But I'm also thinking cardiac, but at the same time, I'm jumping on the sepsis bandwagon right off the bat.
Yeah, that's quite a popular mantra to have sepsis until proven otherwise, because it's just a can't miss. You can't miss it because you got it with the antibiotics, the pressure's up, because there's all these mortality benefits. from a pharmacy perspective, looking at the lab, yeah, the white blood cell count, the anion gap's pretty high, and I relate that to the lactate. If you do your mud piles or whichever acronym you use for anion gap acidosis, the L stands for lactic acidemia, so that makes sense. And they're right on the edge. They're just below the normal pH of 0.35. So we're probably catching them pretty early, and they're compensating okay, but that's only gonna last for so long. And doubling back to the temperature, most people would think, oh, that they don't have a fever, it might not be sepsis, but if you look at the Sears criteria, there's also low temperature, so less than 35 degrees Celsius, which I believe is for less than even 35 or 36.
So with a glucose of 236, you thinking any problem with ketones in your anion gap? Not really.
Less so. I would look at their history, like
Sure. Sure. Yeah.
Kind of sharp response.
All right. So the patient saw his cardiologist a week prior, was feeling well at the time. A few days later, he went to urgent care because of a productive cough that he was started on azithromycin, likely for bronchitis. He denied any fever, a few nights of chills lasting about 30 minutes at a time. He continued to have short of breath over the week and became progressively more restless and tired, associated with some more increase of breathing, brief periods of dizziness, a little bit of daytime sleepiness, denied any chest pain or swelling of the extremities, denied any nausea, vomiting, diarrhea. He didn't report any complications with the medications he took. Findings consistent with fluid overload, cardiac enlargement, central pulmonary vascular congestion, and pulmonary edema. So this is his chest x-ray. I don't think we really need to explain much on this. I mean, that is not.
That's not good. There's one thing, I don't know if you'll be able to see it. Everyone's heard the term air bronchograms before. Right, so pretty prominent air bronchograms in that left lower anterior to the heart. You can see the bronchi, the lighter area, as it's moving through all that sort of consolidated lung tissue. So you can see the outline as the airways kind of go peripherally. Normally you would not be able to see that. So it tells you there's something in what would normally be air-filled alveoli is now liquid-filled. There's infection or something in there. So.
Yeah, this is what we refer to as a PharmD positive chest X-ray, because even pharmacists can tell us.
All right, Jay, I got an echo here. Can you push play on this? All right, how do I do it? There we go. So we do a bedside echo. I'm not an expert at looking at these for the most part, but the left ventricle looks fine. Mitral valve looks fine there. The right ventricle and what are you doing? They all look good. Anything pop out at you, Dr. Tianson?
Yeah, not really. I don't do a lot of echoes. Normally we would look for, things like a large pericardial effusion, something that might show tamponade. To me, the septum and the wall motion looks a little suboptimal. Again, I don't typically read these, so beyond that, I don't see a large effusion.
So let's say this echo was done when he was hypotensive. How much stake should we put in this echo if he's hypotensive? I mean, we're not.
Well, that's a really good question. I don't think that if I saw this patient and this echo was done at the bedside, unless I already had a strong suspicion that there was a cardiac event, like EKG changes, massive troponin, something like that, I probably wouldn't have this available. So I probably would still treat it. Just treat the hypotension, oxygenate, manage your ABCs, do the basic stuff or stuff.
Okay, so the clinical findings they had was overall impression of some pulmonary edema, heart failure with reduced ejection fraction, mitral valve regurgitation, which was consistent with an echo he had, I think it was 6 weeks or 6 months prior. no signs of pulmonary embolism and no signs of pneumothorax. His pro BNP is 17,000. What does that mean to you?
So that's CHF typically.
Okay. So does that change your mind on sepsis or cardiac, or you still haven't made a decision yet?
Yeah, I think it's still undifferentiated. There's still a lot of things still potentially at play, or both, two things. I mean, it's not the most common thing that you would have pneumonia, sepsis, and also cardiac event, and something else going on. It's not impossible. It'd just be less likely if you had a couple of two things going on at the same time. So I still would call this undifferentiated. I would treat, the CHF. I would continue to do that, and I probably would go ahead and start antibiotics since we have criteria. And to me, that X-ray looks more like there's consolidation rather than a diffuse CHF type of picture.
So decision point number 3 here, you're going to put an art line on this person?
I would.
You would not? Okay. The areas here, it seems like, and I'm not judging by any means, but when, if I go to Essentia or if I go to Sanford, they don't push the art lines that much. Down at teaching hospitals like HCMC, when I've gone down there, they've had ER residents that are eager to put in art lines as soon as we get there. So it's kind of the difference between the two. I think if we were a teaching hospital, maybe that would be more of an option to put it in. I don't know, but
we just typically titrate based on that.
Sure.
And
Yep.
we titrate our pressures that way. And I don't feel that, at least for me, it's worth the extra effort. They're going to get one when we go to the ICU, but I find it super helpful for titrating pressures.
So you said antibiotics. Cody, you want to comment on antibiotics at all?
Yeah. So with sepsis, if you kind of have a general idea of a source, like a pretty solid, like this, we're really thinking it's probably pneumonia. So we probably need to mainly cover for respiratory bugs. So still our gram positives and gram negatives, we need coverage. So a lot of times we'll do like cefepime and vancomycin. Often we won't. Some will add new cefepime flagyl to add the anaerobic coverage, but anaerobes are less likely in pneumonia. Even in aspiration pneumonia, it's usually pneumonitis and less so like an empyema or an abscess. So typically you just got to cover the gram negatives and gram positives. So pretty much vanco is always going to be for gram positives. I rarely use linezolid, which is the recommended alternative. Luckily, most people's allergy to vancomycin is just an infusion reaction, which can be mitigated by free meds and a slower infusion rate. And in terms of like the gram negative coverage, a lot of guidelines, and I see a lot of outside places do like Zosyn or Mirapenem, which are appropriate, but those can get a little expensive sometimes. So potentially doing the ceftriaxone or not cefepime or potentially like a respiratory fluoroquinolone like levofloxacin, and then plus or minus flagyl to either of those to get anaerobic coverage. If you're not super solid on the source, like it could be intra-abdominal, it could be urinary, then you kind of got to cover it all with the gram positives, gram negatives, and the anaerobes. And sorry, one more thing. And the timing on these, the biggest thing is like within an hour, because the literature shows it kind of ranges the estimates, but for every 1 hour that you delay antibiotics, it's about a 10% increase in 1-year mortality. So there really is noticeable benefits in mortality with getting those rapid antibiotic administrations.
I'm going to cover that in like 10 slides.
Okay.
Just kidding. All right, so give the antibiotics. This is not where resistance comes in. It comes in 2 weeks of antibiotics. It's not going to come in this one dose of antibiotics. So if you're in doubt, maybe it is cardiac, just give the antibiotics. Would you agree with that? Yeah. I think as somebody that goes out into the community in both of our states here, I would say 90% of the time, everybody's really good at preloading those antibiotics and the broad spectrum antibiotics. But again, we always can do better, right? So we've got our hypertension taken care of, and it doesn't do anything to our rate. Which one you want and why?
So in this case in particular, and for most patients with AFib with RVR, amiodarone is a great first option. In this, it compares it to esmolol, which I would really caution against because esmolol is a beta blocker, so it has negative inotropic, so the contractility of the heart as well as chronotropic, so the heart rate. So it'll both lower your heart rate and the strength of your contractility of the heart, whereas amiodarone is only a negative chronotrope, so it'll just lower the heart rate, but it will not affect the heart's contractility. So in this case, I would really like amiodarone. I don't think I would ever say esmolol in this scenario, but it's not completely wrong because we do have the pressors. We would just kind of be fighting against our pressure or our pressors. So.
Yeah, and I would agree with that. I mean, cardizem, metoprolol, sort of things we would use, less acute patient in the ER to try to slow the rate down. My decision making on this always starts with how stable are they. So blood pressure's fine, and you think they can tolerate this stuff, then try rate control. If they're unstable, then you have to consider cardioversion for sure.
All right, great. So they went with esmolol and started running esmolol, and then later consulted with cardiology and was switched to amiodarone. And they said the reason that they went with esmolol is because of the half-life. When they shut it off, it's done. They can start something new. I don't know much about these as far as that is concerned. I have read some literature on esmolol and AFib with sepsis and how it is a better choice than amiodarone, but it was a very weak study. So it's still up in the air on that, but great, thanks. So the patient was admitted to the cardiac ICU unit. Obviously, they consulted with cardiology. They didn't take him to the cath lab, which I don't think would be appropriate. Switched him over to amiodarone. And the esmolol worked very nicely, but cardiology wanted amiodarone for those exact things you said. They had him on non-invasive, and later up in the cardiac unit, they electively intubated him because they got his sats up, they got his end tidal up, but they couldn't get his breathing under control. He was still breathing at a very fast rate and starting to tire out, so they elected to intubate him. Is anyone, you guys ready for the final on what it was? All right, so it was viral sepsis. So the great Mr. Mysterious Sepsis wins in the end. He did have CHF. He was fluid overloaded, so he was successfully diuresed. He did get moved from the cardiac unit once they figured this out to the medical unit, but he walked out of the hospital, I think 15 days later, and I think it was some of the great care in the ER that happened, the attention to how severe this is. So at the end here, I'm just going to talk about my types of responses. So I come in with a trauma, and this is what I get. You get, here's me with my flight suit on, pushing and pulling my way in, and I don't know, the guy lifting the sheet there, that could either be Cody or Jeff taking a peek. You got some residents up at the top. You got anesthesia there, everybody charting. Everybody's there, the cavalry's there. And then you have cardiac arrest, and it's the same thing. You have your MD in the middle there in the green scrubs, and your nurse doing compressions, RT's ventilating, or anesthesia, whatever. And then you have sepsis. Hi. Hey, you're in septic shock. This is something that it's very apparent that we don't pay attention to sepsis enough. This is kind of what Cody hit on right away, your early antibiotics. This scale I found on, I didn't check the credibility of it, but it looks good, so we'll go with it. The same with this one here. I didn't check any of this stuff either, but again, it was presented very nicely, so I think it has a lot of credibility just from how it presents. So, sepsis is very costly. When you look at hospital readmissions, it's up to 12.5, which is compared to 6.7 with heart failure. Before I saw this, I don't know if I would have believed that. And sepsis readmission is way more expensive than anything else. So it is a big, big burden on our hospitals is readmission from sepsis. Here's my references. I don't know if anyone cares about that. So that we're coming to the end here. I just want to give a plug for another hat I wear at Sanford. I also work for SimND, which is a grant that we acquired probably 12 years ago now, that from Leona Helmsley. We bought 4 of these trucks throughout North Dakota. Here's the map where we sit. So each region has their own truck. Trinity Hospital has one, St. A's in Bismarck. We share ours with Essentia, and then Altru has one in Grand Forks. And what we're designed for is to go out into rural health and do education for whatever you guys want. It kind of shut us down through COVID, so we're kind of getting us back out there. Here is some information if you ever want to schedule anything to come out and do education for your team or any of your people. It's free, so it's all free. Sanford pays my wages when I'm out there. We don't bill anybody on this. We just got approval to cross state lines, so we can go over into Minnesota now. We have chapters all over the United States. We have one in North Dakota, one in Montana. South Dakota is where it originated from. We have one in Wyoming, Nebraska. Iowa is just finishing up theirs, and Minnesota is just starting to write a grant on this. Now, when I say that, I was told 8 years ago that Minnesota was starting to write a grant on this, so I'll see it when I believe it. Other than that, that's all I have. My name is Reed Growth. Please send me some feedback on if you hated it, if you say you are terrible to look at, don't ever leave the house again, you spit when you talk, you stutter, I can't understand you. I want to get better at doing these sorts of things, and this obviously was a run. I want to thank these guys and you guys for being my guinea pigs on this shadow boxing that we're doing, and thank you guys for having me, and that's all I got.
We do have time for some questions.
Oh, there'll be no questions.
I do want to just, the PowerPoint for this one, Reed asked that we don't post it beforehand, so people are looking ahead. It's always nice to think through it. Students hate it when I do that at UND, so I'm not the only one, so there. But there was one, actually it's not even a question, it's just how do you contact people and why not, so I will pass it on. But anyways, this will be posted.
Just yell it out. Who is thinking viral sepsis? Who is thinking cardiac? Who is thinking respiratory? You can yell. Sepsis. How many people would have intubated right away? Yeah, I probably would have too. I don't think I would have even transported them non-invasive. But again, like I say, I'm a bull. I like to do that stuff, so I probably do it more than I should. In his case, I don't think there's anything wrong with intubating him early because he needed it. But any other questions? Pose them to Jeff and Cody because I'm not good at it.
I would just add on that, leaning towards intubation, especially if you're getting on the road and you're going to transfer. If you're out there for more than 20 minutes, there's definitely risk to having to stop, intubate someone in the back of the truck. If you're not in the hospital, you don't have backup, you don't have resources. And, it just puts you in a more difficult situation than is necessary. So that's why I think I probably would have not faulted anyone if they just said, I'm going to intubate this guy. Remember the vitals at the beginning too. We could see probably wasn't going to be able to hang on that long, and just probably safer not only for the patient but for the crews. The last thing they want to do is stop on the side of the road somewhere and do a procedure. It just puts them at risk as well.
I work in hospital some, and blood cultures. Please tell me they were done. There's no mention that I saw.
Yeah.
Thank you.
The sepsis bundle.
I don't think it was.
Oh.
No.
I don't know what you guys do, but.
Anybody else?
Working in a rural ER when you don't intubate a lot, what can you talk about other options for airways that you could use?
Well, that's a good question because Jeff is actually the medical director for the paramedic school. So
That's right. So you have many options. I mean, it's just a continuum of things that you want to do. The first thing you're going to do is supplemental oxygen for sure. If there seems like there's any sort of obstructive process, like they're sleepy or their tongue is falling back, a nasal trumpet, nasopharyngeal airway might help. You can always try BiPAP if you have that available. But there'll be times where that's, if those things all fail, you're just going to have to intubate. And knowing that it's something that you don't do very often, again, just like we talked about before, those are the things that are the hardest, high risk things that you don't do often. And having the sim truck maybe come out and practice, you just have to do it. You can't be good at something if you don't do it. It only comes in every, once a year or once every 2 years. You're just going to have to practice on maybe a sim lab or something just to try to keep some level of comfort with the equipment and actually how to do the procedure. Yeah, I mean, all of those are stopgaps, Lima, and there's, those things will help, and we do see those. They do work well. That's still an option. Now you're shoving something in their throat, and now you've got to deal with that, make sure it doesn't move. It's not as definitive, obviously, but we see that. I don't think I've seen one in a while, but it seemed like there was a period, maybe more over the last 2 years, where a lot of people were coming in with Limas. If it was, a real crash and fast moving situation in the field, sometimes that's a good option. Sometimes there'll be an attempt and they just can't see back there and they just shove that in there too. It does work. That's a reasonable option. If you don't have the option to intubate, for sure, go ahead and try.
And that's part of the whole shadow boxing that is the goal of making you guys think about all these high risk, low frequency events that Jeff was talking about. Visually, mentally preparing for this is your first step. So you asking that question, I don't intubate that much, but thinking about if this patient does roll into your ER, where's my kit? Where's my glide scope? Where's my backup ET tube? Where's my iGel and my King Airway? Where's my cryo kit? Do I have a cryo kit? Putting those trains of motion and thought in your brain. That was Gary Klein's biggest thing, was to get people to mentally, visually think that through. Does that make sense? Track it.
On the blood culture note, I've had like differing opinions on the drawing when you start antibiotics and that fight. What would you say, Cody?
Yeah, I know. I believe the guidelines said it specifically, but really we shouldn't be delaying antibiotics if that's going to be required to get the cultures before we start antibiotics. So if there's no one available to grab the cultures and it's going to result in a significant delay in antibiotics, then we need to just give the antibiotics. Luckily, with blood cultures after antibiotics, we can usually still get something. We can at least stain it and kind of differentiate it that way. But yeah, the big thing they emphasize is do not delay antibiotics. Almost nothing should delay antibiotics short of them coding. And then still give another line available to start the second line.
And to me, that's a relatively easy one too. The mortality benefits from the antibiotics. It's not from fresh blood from the cultures. That's more something you need later, but the antibiotics are precise.
Thank you.